I'm excited to hear how AHIP goes later today and tomorrow.
Yeah, I think it'll be good. Number one, it's great that it's so close, but it feels like there's so much in the air, as we are certainly going to be talking about later today, um, especially Klump's comments last week at Stat. And so much to consider, much to consider.
Yep, it's going to be an interesting couple weeks. Final notice is what? It's like April 6th?
So it is sitting at that. I think that's the last possible day.
That's the due date for it.
Yeah.
Right. Yeah.
But it is right now sitting at the Office of Management and Budget, and they're looking at it right now. So it could be any moment.
That's exciting.
Yeah. It would be great if it dropped like right as Klump was getting on stage.
Mic drop. Don't need to say much beyond that.
But yes.
Yep. That'll make for interesting conversation for sure. It's today, tomorrow. Does it go to Wednesday too?
Wednesday as well. And today's a half day. Wednesday's a full day. It's at a hotel that I go by every day, and I've never been inside of it. So I'll be excited to see what it's like.
Seems like a good excuse for that.
Yes. And it is on the route that Mimi takes home. And so she's just going to scoop me up on the way home today.
Even better.
Yes.
That's what I like to hear.
Getting shuttled is nice. It does look like it's going to rain. And so, but it's also, yes, it's also very hot, like and humid and mucky in DC today. And so it's like, I don't want to wear a rain jacket. And also I don't want to schlep all the way to the metro.
These are the hard life choices one has to make, Martin.
I know. It's really, I have a rough life.
Yes.
A rough life.
And give it another 30 seconds and then get things started.
Yes. I tried to readjust all of my photo frames to make sure that they were even, but I now feel self-conscious about them after last time, Kevin.
It's okay. They're pretty good. There's a few I can give you feedback on later. But we can check in after this. Should we get things started?
Yes.
Morning, everyone. My name is Kevin O'Leary. I am the Upper Midwest Regional Division of Health Tech Nerds representing. Although today, Martin, I'm checking in on the road from Pacific Northwest. Excited to get back home soon.
And I'm Martin Check from the Mid-Atlantic Regional Division of Health Tech Nerds. This week, we're talking state-directed payments, an early update on the Wiser model, and how people feel about prior auth. And in just a little bit, we'll welcome John Zutter, CEO of Lantern, to talk about their recent fundraising round. But first, we've got a health system mega merger to discuss. Kevin, what is going on with your former employer joining up with Sutter Health?
Yeah, so my last job before starting Health Tech Nerds. Early last week, Sutter Alina announced a letter of intent to join forces. Combined system, I think $25 billion in revenue they're talking about, 39 hospitals across California, Minnesota, and Alina's in Western Wisconsin too, but I think Twin Cities region for the most part. As part of the deal, $2 billion invested in the region in Minnesota, Western Wisconsin. It's, as I was looking at it, it's kind of a logical cross-market merger in many ways to me, to the extent there is a logical cross-market merger. The Minneapolis market, it's felt a bit like a game of musical chairs over the last several years where nobody feels like they're on the most solid footing, but you don't want to be the one who's left out, right? There's lots of financials issues obviously afoot in the Twin Cities right now between everything going on in Medicaid. We just had UCare go under. So it's an interesting landscape in the Twin Cities healthcare market. Historically, you've had an AG who's not friendly to deals like this and is a thorn in the side to him. I think it was 2023, you had Sanford Health from South Dakota trying to enter the Minneapolis market via merger with Fairview. Ultimately, that was nixed. So in a lot of ways, you can imagine why this feels like a reasonable time if you're Alina leadership, if you're Alina board, to move forward with a deal with a larger partner to to find kind of what I'll call long-term strategic safety, right? Alina's been on road to recovery from a profits perspective the last couple of years in terms of operating profits. I don't think that road is complete yet. And so if you're looking for partners, and Sutter is out there in California and in a position where they are looking to grow nationally, right? They just put a roll in January, February earlier this year. They brought in corp dev leader to grow the business nationally. Makes a lot of sense that if you've got one organization looking to grow nationally and one looking for a partner to help drive scale, that you'd find each other in this market, right? So to me, that feels kind of like the general strategy at hand. Traditional cross-market merger, find scales for two entities that are looking for partnerships in different ways.
The joke from your newsletter and from the press release was that they are referring to the Minneapolis or to Alina as the Upper Midwest region. I prefer Great Lakes for that area of the country. I don't like to be associated with other parts of the Midwest, but I thought that was a sort of a funny thing to say. We've got the Upper Midwest region of Alina.
Yes. You've got 38 hospitals. Sutter is only in California. And you add in a group of hospitals in Minnesota and Western Wisconsin. And imagine the conversations that are leading up to the announcement, the press release, where they are redlining this. And it's like, no, Alina's the Upper Midwest version of Sutter, region for Sutter. It's like somebody is going, okay, we might have another directional qualifier for Midwest at some point in the future. It seems to me very indicative of what Sutter has in their plans.
Yeah, between the hiring of the M&A director and the upper regional qualifier, it really does feel like we'll be seeing a lot more of this from Sutter. For those folks who aren't as clued into the Twin Cities hospital market, where is Alina in the universe of hospitals in the region?
It's right at the top. I want to say, don't quote me exactly on this, but call it 33% market share in the Twin Cities region. It's one of the couple major players. mHealth Fairview's in town too. Park Nicollet, which is part of Health Partners, is in town. But it's one of the big brands. Obviously, you've got Mayo Clinic to the south of us in Rochester, Minnesota. Mayo has never entered into the Twin Cities market in a meaningful way, but that kind of strategic threat has always loomed over the Twin Cities region, like the what if Mayo enters Twin Cities market, takes a lot of commercial share from the other health systems in town. Where does that leave you strategically? Sanford has always seemed to have an interest in the Minneapolis market, although that's where the AG issues over time have cropped up. So Alina, in terms of the Twin Cities, it's a well-positioned health system in the broader ecosystem, right? Abbott Northwestern is kind of its crown jewel hospital, which is kind of the crown jewel hospital in Twin Cities area. So yeah.
I, not having ever lived in California, only know Sutter Health from former HHS secretary who used to be the Attorney General for California, suing Sutter for anti-competitive practices, Xavier Becerra. Basically, a lot of all or nothing contracts. There's some great graphics you can find of prices in Northern and Southern California in and outside of Sutter's market, and them being a lot higher in Sutter's markets. They issued a press release, and the press release had some, really exciting stuff. They're going to improve patient access and affordability, help caregivers spend more time with patients, drive high quality and safe care, make it easier for patients to get appointments, accelerate physician and clinician recruitment, advance discovery, and be one of the best places to work in healthcare in the nation. That all sounds pretty great to me. I don't know about to you, Kevin. Sign me up.
I'm very excited about what's to come to the Twin Cities. If any of that materializes, that sounds
and
great.
Western Wisconsin, which I consider part of the Twin Cities.
I don't want to leave them out. Yes, we should bring our Wisconsinites in.
But historically, these sort of mergers. Well, let me just say this: there's not a ton of evidence that these sort of mergers typically do that. So the Leonard David Institute at The University of Pennsylvania has some great research on this. This is something they like to talk about. Hospitals issue, cynically, roughly the same press release that I just listed every time they're doing a big merger like this.
Yeah, it's what you have to say, right?
Yeah. And there is no evidence, according to the Leonard David Institute, that these sort of mergers improve quality. There's some evidence that maybe it reduces quality. There's also lots of evidence that it raises costs. Now, to be fair, the American Hospital Association has also done its own research, and they've said that acquisitions are associated with a 3.3% reduction in annual operating expenses per adjusted admission, and operating expenses fell by roughly 5 to 6% on a per bed basis following an acquisition, with an associated increase in operating profit of about $60,000 per bed per year. So theoretically, there are efficiencies to be gained. The challenge comes with those efficiencies making their way into lower costs and better access for patients.
Yeah. I mean, in many ways, it feels like the health system version of the Medicare Advantage debate. Does it drive cost savings? Does it not drive cost savings? You're going to have people on both sides of that debate. And while the answer seems like it should be knowable, like there should be a fact underneath this that's like, yes, this is what's actually happening to costs in the market. The different ways you can interpret it are going to lead to arguments on both sides. Personally, I don't find the AHA argument all that compelling. As I look at cross-market mergers of health systems, I am not going to be holding my breath waiting for that list of things that Sutter is articulating for Minneapolis market to come true. I think it's just the reality of mergers like these, right? But I also think, like we were talking about this in the Slack conversation this week, there's kind of a societal debate over, are cross-market mergers a good thing? Are they going to reduce costs? Are they going to have the synergies that we all talk about? Which I think are fair questions to ask. Then I also put myself in the shoes of, if I am leadership team at one of these systems or on the board of directors of one of these systems, these institutions are good things for their community, generally speaking. And you are going to believe that if you are one of these folks in those roles. I believe that from having worked at Allina. Like, it is a good institution for the Twin Cities area. And if you start with the series of questions you ask yourself from that framing, it seems like a very natural conclusion to get to this place of, this is a good thing. We want to figure out how to put it on stable footing on an ongoing basis. Yes, there are issues with any merger and things that come up and so on and so forth. But ultimately, this is the right thing to be doing for the health system, you know? So I get it. I see why they're moving in that direction. Now, will it actually play out that way? I don't know. I also think it's going to be interesting, Martin, to watch kind of the various efforts to build this national health system. Like, it very much seems Sutter this is the first step among at least a handful of other steps to bring other health systems into the fold. And you fast forward that 5 years, and whether it's Sutter with their effort, whether it's Kaiser and their Risant effort, there's some interesting things going on in terms of kind of this concept of a nationwide health system.
Yeah, I think that you can tell a story about the future being a handful of large nationwide health systems.
Yeah.
Increasing concentration leads to increasing need for economies of scale. The dynamics, taking a step back, the thing that usually drives the increase in prices for patients is that when you have a merger among health systems, their market power increases. In this case, you've got Sutter in California and Allina in the Twin Cities in Western Wisconsin. It's not like the market power is going to be changing radically on day one. I expect we'll see some improvements in sort of operating leverage and operating costs. The question is, they talked about these $2 billion worth of investments, and those investments, I think, are around to drive market power, to create more market power, so that when Allina or the upper Midwest region of Sutter Health has a negotiation with an insurance company like United, they have the leverage.
Yeah, for sure. Allina brand is staying in the local market, by the way. So we're not becoming the the Upper Midwest Regional Division of Sutter everywhere. I'm curious to see what the swag mugs look like coming out of a deal like this. Like, what is it? Still Alida Health that gets printed on the mug, or is it Sutter Health, Upper Midwest Region?
It is, I think, interesting in the context of the conversation that we're headed into in 2 minutes with John from Lantern to think about this idea of networks of excellence. And you have hospitals increasingly pinning their strategy on building larger and larger conglomerates. And then companies like Lantern who are going and saying, this doctor at this hospital is the best at this surgery. You had that great conversation with Tom Friedman from the North Carolina State Health Plan. And it's in many ways a sort of dissecting those conglomerates and saying, here's what we want from you, and we'll bring you volume in that respect.
We could stitch together some really interesting, like at a very macro level, the idea of a provider network and how you stitch together that provider network feels like it's going to be interesting to watch over the next couple of years, right? You've got the proposed changes in the ACA around no network plans and those coming to market. Those have their puts and takes, right? You've got the sort of work that Lantern is doing in terms of building out center of excellence type model. And I'm curious to learn how they are thinking about building that out versus kind of traditional center of excellence approaches. That'll be really fun to hear. But yeah, it presents this really interesting question of if you're running a large cardiology group, you want to negotiate rates for that entire cardiology group, right? And you want to negotiate the best rate possible. If you're a payer, on the other hand, or a patient, you want to know the specific cardiologist within that group that you are going to. What are their quality outcomes? What are their cost outcomes? And how you dictate that? And so there's some interesting questions to answer on network builds and designs over the coming years, it feels like.
I was having a conversation with some folks about staffing software, and they were talking about how they see staffing software as being this huge part of operating leverage for health systems and medical groups going forward, because getting the right doctor and the AI in the loop and all of those things to fire at the right time, the community health worker to go out and do the thing, is going to be absolutely crucial in a increasingly complicated staffing model or care model.
Yeah, I buy it.
So we are excited to welcome John Zutter. I'm bringing him on. Hi, John.
Hey, guys. Can you hear me?
Yeah, we can hear you. How are you today?
Not too bad.
John, congratulations on the round, $30 million from Morgan Health and Echo Health Ventures.
Yeah.
Welcome to the show. And I'm going to kick it over to Kevin to kick us off.
Great.
Yeah. John, congrats on the round. It was fun to read about that last week. I'd be curious, I don't know if you heard us just talking about kind of network builds, how you're thinking about center of excellence model. How do you think about Lantern's approach to building that network out versus kind of traditional center of excellence models as probably most folks think of them in the market today?
Yeah, I think that one of our biggest points of differentiation over the years has been that we have kind of evolved the thinking around centers of excellence from what they were in yesteryear to what they are in a more practical and usable fashion. And so like a little bit of our origin story, if you go back, we used to call ourselves a surgeons of excellence network rather than a center of excellence, because one of our first clients was a school district in Western Houston, and they didn't really care very much about what was our access to or rates with big institutions like Cleveland Clinic or Mayo Clinic or HSS or the names we typically think of as centers of excellence, because none of their people were going there. Right? And so their kind of problem set was, how do we get people to high quality care at affordable prices in our community? And to do that, you really needed to cherry pick the individual doctors, and you needed to be thoughtful about the individual facilities. You needed to be thoughtful about site of care. And so, kind of from our genesis, it was solving that use case of how do you deliver what people thought of as center of excellence quality, but do so on a much more distributed basis in the community setting where possible, with the safety net of those big institutions for the scary stuff. And it turns out that just scales a whole lot better. It scales better for a couple of reasons. One is most hospitals around the country are going to have a pretty diverse range of docs in their panel. and a few of them are going to be exceptional, and a few of them are going to be less so, and a bunch are going to be somewhere in the middle of that bell curve. And so if you can positively select, you can deliver really excellent quality care on a distributed basis. The second piece to that is, if you can do that on a distributed basis, you don't have to pay for the cost of travel, right? Which, if you're going to send someone for a surgery somewhere where they're going to be under anesthesia, you got to also send a travel companion, right? Because you can't be discharged after general anesthesia without someone with you. And so now you're paying for two people, hotels, flights, all the rest of it. And that's just a fixed cost that you can't really amortize. And so when you think about the original centers of excellence, they were very narrow in scope to, joint replacements, spinal fusions, cardiothoracic events, bariatrics, and kind of that's it, which meant you were already starting with such a small segment of the market. But when you can eliminate the travel piece, you can, not have to amortize that cost, which means you can go to lower acuity type of procedures, and you can simplify the message to a population to say, do you need a procedure? Give us a call, right? So that's kind of unlock one. Unlock two is, not surprisingly, it turns out members don't really want to get on planes before major procedures. They don't think the idea of getting on a plane after they've had a spinal fusion or something like that sounds particularly attractive. And so you see that come through in the data. If you ask someone to get on a flight versus stay in their closest, most proximate metro area, it's like an 8x difference in utilization. If you ask them to drive a couple of hours, right, from your metroplex to the next closest major metroplex, it's a 5x difference in utilization. So people want to stay local where they can. You can achieve great outcomes. You're often starting with a lower price index versus going to those highest acuity, biggest brand name places in the first place. And so that all kind of creates this flywheel effect of cover more conveniently, drive higher utilization, while still being able to, bring in some of those big institutions. So, to your question, from our get-go, we've always been more of a specialty network than a centers of excellence. Centers of excellence is kind of, by definition, much more narrow, more myopic, and leads to the problem that we see so much in digital health, which is like, great idea, nobody used it, what's the point? Where here it becomes, practically accessible. I think last year, across, all of our book of business, on average, people were going, in the dozens of miles range to get to the care that they needed, rather than hundreds, and certainly not flights by a very, very, very small frequency.
In addition to building this network of excellence, so you're working across cancer, surgery, and infusion at the moment. What does the experience for the patient look like? Like, when the patient is saying, okay, I have this procedure, I'm calling Lantern, what does those services look like?
Yeah, so we've put kind of a concierge wrapper around that whole experience. So we've got a team of 350 or so care advocates that answer those calls, or answer live chats or asynchronous chats. So we can do it kind of omni-channel, but you're going to be paired up with a care advocate. And if I'm your care advocate, I'm going to, one, explain to you the difference between, if you're going to go through your traditional insurance, whether that be Blue, United, Cigna, Aetna, whatever it might be. Here's how doctor selection works. Here's your range of choice. Here's your deductible. Here's your coinsurance. Like, here's what that process looks like. Status quo. If you engage with us, we're going to help you at these various different points. We're going to help you choose great doctors that meet your specific needs. Here's how we choose doctors on a quality basis. Some of those attributes that we look for. We try not to drown the member in kind of all the excruciating detail, but give them a little bit of comfort that we're doing a lot of analysis around that. Here's the financial, what's in it for you. Almost all of our clients are waiving deductible, coinsurance, co-pays. It depends based on the plan, but providing a material financial incentive to drive that engagement. So we're going to talk to them about kind of the financial burden or toxicity that exists status quo, and how we alleviate some of that pressure, and then walk them through each step. And once they've decided, that sounds interesting, we're going to send them a selection of providers with bios and profiles, so that they can kind of be empowered in their own decision making. But we're only sending good choices, the only choices that have met our quality and our cost standards in our network. They then choose that doctor, and from there, we're going to help transfer medical records, help with scheduling, check in with them, make sure they're ready for their consult, they're ready for their procedure if one is necessary, that they're recovering well after the fact, and then also creating connection points across the ecosystem if and when those are appropriate.
John, I'd be curious when you talk about the quality data. What quality data are you looking at? How do you delineate between kind of high quality, good quality versus less so?
Yeah, so there's a lot of folks that talk about how to do this.
Sure.
And there's a lot of different tools, and I think they have their pros and cons. We try and pull together data from a lot of different places. So there's standard regulatory data that exists on every facility. CMS puts out tons of data. That's kind of table stakes, right? So we're pulling in lots of attributes, both from CMS directly, from Leapfrog and sources like that. We're looking at what I'd call associative criteria on the front end. So training, board certification, malpractice, state sanctions, all that stuff, which, sometimes folks make light of it, but it's really important, right? It's, again, a table stakes item. It's not where it stops, but that is an important part to both check on the front end and continue to check. Like one of the worst things that can happen is a member gets a provider recommendation, Googles them, and sees that they're being sued for something, right? You're going to lose all confidence right there. We then actually go and work with custom data at the provider level, where we have by specialty, specific applications that have been developed by ourselves and our medical advisory board, where it's, hey, you're a joint replacement doctor. I want to see your case logs by code. I want to see your volume. I want to see your outcomes. I want to see what are your kind of protocols pre and post surgical. So we're looking at things like that. And that's all part of a provider specific application process that, no one on the growth side of our business has a vote in. It's 100%, controlled by the clinical side, so that they get to control that. We look at appropriateness measures. So we use a group called GAM, or the Global Appropriateness Measures, which, there's a bunch of different tools out there, and we like different ones for different purposes. They tend to be very, deep in specific things. So not, are you a good orthopod, but are you appropriately doing spinal fusions, on the right patients? Are you appropriately doing knee replacements? Are you not doing knee scopes before knee replacements at the wrong frequency, right? That would be a negative indicator from an appropriateness perspective. So we have a collage of that data, and then, of course, our own. I think we're the only COE or specialty network that has our own, federally licensed patient safety organization, so we can collect information and assess outcomes when things don't go perfectly. We also, collect patient-reported outcome measures. We're doing a study on some of those as well. I think often, just asking the patient how things went is highly correlated with outcomes, and understanding where they think they are is highly correlated. So we look at all of those different things. So it's kind of a collage of different approaches, proprietary and aggregation of lots of data sources.
I'm curious how those conversations go when you're building the network. Like, what does it look like when you approach a provider and you say, you appear to be a rock star when it comes to this. We want to bring you in network.
Yeah, so it's interesting. We have a situation recently where one of our long-term provider partners has a member of their practice that didn't meet all of the criteria, and the answer had to be a tough answer, which is like, we're not going to change our criteria, and we'll continue to monitor that provider. And if some of those variables change over time, then we can have another conversation. But that can sometimes create tension. Sometimes it's an asset. We have some groups who say, hey, we know in our group who's really good and who has less experience, who's earlier in their career, earlier in their training. And it's hard politically for us to say that, but you guys have an objective criteria, and that creates some separation. And so, the key for us is create a set of rules and follow that rules religiously, and don't deviate from it unless the evidence tells you that there's a reason to update your rules, in which case you're evolving for everybody, but not making exceptions. And I think that's the only way we maintain credibility.
Yeah. John, funding raises are always good times to check in on commercial traction for businesses, big milestones for organizations. I'd be curious, we obviously heard from Tom Friedman the other week about the progress in North Carolina. I'd be curious where else you are nationwide, how far along you are in the build, and also like where do you think this 30 million takes you from a commercial perspective?
Yeah, so importantly, we've kind of always run our business a little bit differently. So we've been, a self-sufficient business for years. The many of our capital rounds that we've announced over the last 5 years were secondary, not primary. So when Cerent invested in 2020, when Insight invested in both 23 and 24, those were 100% secondary. It's just investors transitioning because the company was already self-sufficient. Continues to be the case today. We viewed this as an opportunistic way to partner with folks that could help us strategically as we think about evolving the business, and in particular around the role of indirect distribution and partnerships in the channel in the go-to-market. Where are we from a business perspective? I think for the last 3 years have won between 60 and 70% of opportunities in the marketplace. And that's fairly consistent in that range between those 3 years. We track it pretty rigorously. I think the market continues to get bigger. We're in a really great spot, right? If you look at business group on health surveys for the last several years, musculoskeletal, centers of excellence, cancer are amongst the top 3 priorities for the overwhelming majority. We just got back from our 3 client summits where we at each host about 20 jumbo and super jumbo names, so call it 60 over the course of 3 months. And a year ago, they were surprised, or they expressed surprise that they were going to be in the 8, 9, 10% trend range, up from years prior. And despite macroeconomics like inflation tapering over the last 12, 18 months, in healthcare, it's going the other direction. So the majority of folks in the room were looking at mid-teens, call it 13 to 18% trend for 26 versus 25. Right. Wow. And so when that's the case, there's just no more money to push around. You need real cost containment. And so I think we're in a unique position for that, where the market will just get bigger for us. We do 3 to 5 times the activity of our near peers on any fundamental metric you could think about. And so I think we're in a really good position to continue to kind of extend our lead in that way. At the end of the day, the most important question for a client to ask about is, of course, you have to ask about what are your quality metrics and how do you think about that? And what's your network construction look like and what's access look like? But the most important question is, how much do people actually use your service, right? Because in the absence of utilization, there's not much value and you're just kind of pushing vendors around. We had a client, a very large, call it Fortune 200, well-known brand that was with a near peer for the last number of years and switched to us in January, and heard from them last week that we will have done more in the first quarter than that near peer did in several years in terms of member engagement. And I think that's kind of tells you everything in terms of what's the value of a distributed network versus a network where you might be providing inadequate access and across a too narrow set of procedural categories. And that creates a real kind of network effect from a moat perspective, in that it's really hard to build that network. It takes a long time. The system, as you guys know, is highly fragmented, right? Each market, generally the provider group is a separate entity from the hospital, separate from the surgery center, separate from anesthesia. So stitching that together across multiple different procedural categories, it's putting together a pretty complex spider web. And we have that nationwide, right? So our clients represent, our membership of 12 million people today represents a heat map that looks just like the US population across union, public sector, private sector, super jumbo, middle market, et cetera.
John, this has been hugely helpful. We really appreciate it. We know we're a little bit over time. Where can people learn more about Lantern if they have questions?
So of course they can go to our website, lanterncare.com, but they can reach out to anyone on our team. I think we try and be really active on LinkedIn, try and be responsive there. People can reach out to me directly on LinkedIn or find me at a conference near you. So we all try and make ourselves as present as possible.
Thanks so much for your time today, John.
Yeah, thanks, guys. Happy
Appreciate
to do
you,
it.
John.
See you soon.
Yep. See ya.
I think that conversation paired really nicely with your conversation with Tom Friedman from the NC State Health Plan. The big question, I'm sorry, the big question that we didn't get to ask because we ran out of time was how they're getting those better engagement rates. So I think and maybe you can expand on this a little bit, but you talked about this issue of trust a little bit in the newsletter this week and had an interesting conversation with Tom about trust.
Yeah, I mean, so context setting for this, right? North Carolina State Health Plan, 750,000 employees, or I should say covered lives-ish on the plan. They brought Lantern in, zero cost surgical benefit as part of their trying to turn the plan around over the next couple of years from a financial perspective, right? I think they're projected to lose, $1 billion, or be a deficit of $1 billion by end of 2027. And so the zero cost surgical benefit is a big part of the offering. And one of Tom's interesting comments that sticks with me coming out of that, he's like, he made a comment of, you think you can design this program, that's where you can stop, right? Like as long as you design the right program and have the right incentives in place. But he's like, when you actually roll it out, you realize that these are folks who are going through health issues and they have a lot going on in their lives, and you need to get in front of them and ultimately drive behavior change for them, right? And to drive that behavior change successfully, they need to trust you. And that was part of the conversation that Tom and I were having, right? Around payers don't do a lot to earn the trust of their members. And that's true of employers as payers as well. And as Tom mentioned, they're in their first days on the job as kind of the new plan administration, they had to raise premiums for their employees to solve that deficit issue. And you can imagine you're an employee of a state health plan, you're a teacher in North Carolina, your premiums are going up and you lose some trust. And you've then got to work to regain that trust as the plan through showing up consistently, through offering programs like these, through explaining why the benefit's there. And I thought it was a really cool example of trying to drive positive change from the state health plan. And then also thinking through partnerships with organizations like Lantern. And they just brought in Novant Health, big health system in North Carolina, to help drive more awareness, more trust, more credibility building in that local market with a provider group as part of that, right? And so I think it'll be interesting to keep an eye on that model, how it evolves over time, how it grows and scales up, because it's cool to watch.
So AHIP's hosting their Medicare, Medicaid, duals, and commercial conference just right down the road from me, as we talked about a little bit in the intro. So I want to talk about Medicare and Medicare Advantage. Let's start with what Chris Klump had to say last week. Made a lot of news. I think that the headline that people are running with is we're going to stick people in Medicare Advantage by default. And I think that that's lacking a little bit of nuance. The quote from Klump, which I thought was a good one, was really talking about accountable care relationships and, Medicare Advantage enrollment, ACO programs, those things they really value. That's been a bipartisan, the CMS has been on the same page about that, whether it's ACOs in original Medicare or not. But I'm curious to hear from you, Kevin, what was your read of that comment?
Yeah, I mean, my read of the quote, the whole thing's in the newsletter. It's from an interview with Mario Aguilar at Stat while Chris was out there last week. I read it, and the key takeaway for me is Klump would rather people go into those relationships than fee-for-service enrollment because he views fee-for-service as the worst of the three options there. And to me, I think that's a reasonable thing to say, right? Like we should encourage enrollees into long-term accountable care relationships. That does seem like a good structural design of a program like this. And then I think there's a lot of questions that are yet to be resolved in terms of is that Medicare Advantage specifically? Is that an ACO? How do you navigate those two things? And I don't know how that plays out, but I'm going to be curious to watch to see. I can't really argue with anything that he says in that quote. I agree with it. And then I juxtapose that with, there was also the Bloomberg headline that came out on Thursday talking about how Medicare Advantage is not sufficiently managing costs on the whole. And I pair those two things together, and it's like, yeah, I can stitch together the narrative in my head of, okay, CMS is trying to move us towards these accountable care relationships. It thinks the two best routes to do so are one via default into ACO through MSSP or what have you, one being into MA. I don't know specifically how you do that, but conceptually that makes sense. But if you're going to have MA as an option, you want MA to be managing costs better than it's perceived to be, as we've talked at length in various podcast episodes, right? Like, you've got MedPAC out there saying what they're saying about Medicare Advantage costs being higher than traditional Medicare, and you should want that number to come down. And you, as the ultimate payer, should be encouraging Medicare Advantage to be doing exactly that. And if they do that, that should lead to better outcomes via the Medicare Advantage program and more enrollment in that program, at least on that conceptual basis. And then the puts and takes starts to get back to, do plans have to cut back on benefits, and does that change enrollment, and all of that kind of fun stuff. But to me, I it's funny how, the Bloomberg news came out and that seemed like doom and gloom for MA. Like, it's not doing a good enough job. And then the other news came out and it's like, oh, we're going to default enrollment into MA. And it's like, what gives between those two things? And it's actually like, I don't think those are conflicting statements if you frame it back to that point of, it's about the relationship for the beneficiary and how all those programs can tie into that and moving in the right direction from that perspective. So I don't know. I thought it was interesting to see the quote. What about you?
There's a very good health affairs article that Liz Feller and Purva Rawal wrote a couple of weeks ago about ACO, like improvements that we could make to ACOs. And one of them is just this kind of silly thing, which is that if you are in an ACO, you probably don't know that you're in an ACO. And you don't get a card. There's no supplemental benefits or anything like that. But it's also, you don't know that you're part of an ACO. And I think what's scary to folks is they're saying like, oh, am I going to get utilization managed, which probably we need some more of. But this is, I think, a particularly good lead-in to what we're talking about next with Wiser and skin substitutes. ACOs were really on the forefront of being able to say, there's something going on with these skin substitutes. Original Medicare fell down on this and spent $2 billion in one quarter, where Medicare Advantage spent $200 million. And the ACOs were out there sounding the alarm because they had a stake in those savings. So it does feel to me like, in addition to some changes to Medicare Advantage, the other piece we need are some changes to the ACO program, so people know what they're getting into and are getting assigned to it, and it is part of the sort of enrollment choices.
For sure. It reminds me, 2015, I worked at an ACA insurance plan, Harkin Health, that we built primary care clinics by Aura Health. And as part of being a member, you got access to those primary care clinics for free. One of the biggest challenges that model had was when people went to healthcare.gov to sign up for their insurance plan, you only see insurance plans. There was no way of communicating, hey, when you sign up for ours, you get access to a primary care clinic for free as an added benefit on top of that, because that wasn't in the standard set of like plan design, meta level, et cetera, et cetera. And so we had all these members who joined who had no idea that they got access to a free primary care doc, which became really problematic for the actuarial model when you build the actuarial table thinking that people are going to use that primary care doc because it's free and awesome. And it's like the whole thing starts to unwind because of the point of enrollment isn't designed the right way. Whereas if you could say, hey, join if you want access to these primary care clinics or these doctors or this provider type, all of a sudden you could change the flow. And I don't know how that happens from a DC perspective, but I think it's interesting to think about.
Yeah, it's a design problem. It is not literally impossible to do.
Right.
Speaking of design problems, so talking a little bit about the WISER program, a program which I'm a huge fan of, the Seattle Times wrote a front page article about how WISER programs are having some rollout challenges in the state. I thought the article, you caught some factual errors in the article. I think that we are going to see a lot more of this genre of article in the next few months because people don't like prior auth. They just don't.
They don't like it. There's a lot of distrust in it at the moment. It is one of those phrases that like, it's a tough word to talk about in the context of a program like this, right? And ultimately it goes back to our ongoing theme of the iron triangle in healthcare and managing the trade-offs between cost, quality, and access. And when you are doing that, you are managing care, you are putting in place things like prior auths, and somebody isn't getting all of the care that they receive. And that leads to a story that you can find about a bad outcome. And that's hard and it's unfortunate. And we should seek to work through that. And it's also the dynamic of American healthcare where we've got more than we can collectively afford at the moment, right? And I think we need to be having those conversations more. And I think the Seattle Times article is a good example for me of why it's so hard to have those conversations because the WISER program rolls out. I assume from a place of good intent and legitimately trying to solve a problem that they see in skin substitutes, right? It is a narrowly defined program. It is going after particularly high cost problem areas in healthcare, and it's trying to help manage cost of care. The ultimate irony in the Seattle Times in the article is that it is part of ongoing affordability for residents in the Seattle area. And it's like, that is talk about that part of WISER too when we talk about this, because I think that is a key part of this question, right? But it's indicative of how complex this conversation is, the challenges associated with it. The vendor that got picked for the CMMI model in Washington is apparently having some issues with rolling out the program. The article talked about how average turnaround time was supposed to be 2.5 weeks, is 2.5 weeks, and it was supposed to be 72 hours. Those are all problems. And back to this like trust building exercise, getting in front of communication, what's going on, doing so transparently, showing up consistently. Like there are things that can be done to build trust in those types of moments, but it's hard to do, right? I don't know.
Yeah.
I don't know. So I personally am a fan of the WISER program. I hope that it is able to get to a place where the benefits of AI as we think about them conceptually show up and we are able to have faster turnaround times. It does lead to appropriate access to care. And it's got work to do, right? As I'm sure the folks at CMMI know, in rolling out a new program, like that's kind of the intent of these programs, right?
And I would submit to you that even if the vendors were doing a perfect job, and even if everything was going as best as it possibly could, people would still be upset about it because people sign up for original Medicare so they don't have to deal with prior auths for the most part. And doctors don't like it and they complain to their patients, and patients don't like it because they think that they want the very expensive skin substitute and they feel like they should get it. And so I don't want to be Mr. like, you got to eat your vegetables, but you got to eat your vegetables.
Yep. It's tough being that person.
I do want to be Mr. You got to eat your vegetables. But want to quickly hit on state-directed payments, one of my favorite subjects. So a nice thing, if you are a state with a balanced budget requirement in your state constitution, which is virtually every state, is that you can apply to CMS and you can say, we would like to increase Medicaid payments, and we would like you to pay for a portion of those payments for a specific provider group. So it could be hospitals who are always saying that they lose money on Medicaid patients. It could be psychiatric care facilities. Basically, you want to make the Medicaid network bigger, and the state-directed payment is a program that you can do that. Mm-hmm. Historically, some states have really gone wild and said, let's make Medicaid payments roughly the same as commercial payments. And the One Big Beautiful Bill Act, HR 1, basically said you can't do that anymore. We're setting a cap at Medicare as an upper payment limit, and if you're an expansion state, it's a little bit less. And when the rule went through, CMS it said 100, the law was passed, and it said 180 days within enactment is the window for applying for these state-directed payments. And this set off like some frantic SDP applications at the state level. And CMS did all of the states a favor, and they said, well, actually, we're going to interpret this as 180 business days. So not 180 days, but 180 business days. And so instead of that window ending on December 31st, 2025, the grandfather effect is now through March 27th, so 4 days from today. And what do you think happened, Kevin?
Tell me, Martin.
Well, I think you will not be surprised that a bunch of states applied for adding state-directed payment programs. So the two states that the Center for Responsible Federal Budget called out were Illinois and Texas. And they took advantage of this flexibility to drive up total Medicaid costs by $40 billion, half of which they're on the hook for. The other half is coming from the federal government. So $20 billion in increased spending because of this little wiggle room that CMS afforded.
That's fun.
It's fun. I think it's one of those things where it is so hard to save money in healthcare, and it is especially hard when someone else is picking up the tab for most of it. But I do really have to appreciate Illinois and Texas saying CMS might be taking away the punch bowl, but we are going to get in a few scoops more before it is fully out of the room.
I was reading up on it. The legislation passed early July, so 180. I was like, how ambiguous was the 180 days in what was originally written? And 180 days from July to end of 2025, December 31st, seems like probably the original intent at hand. Now, yes, adding business days and they're giving it another quarter. I get it. You're throwing some states a bone, and that's part of the legislative process on the whole.
Yeah, it also helps the medicine go down a little bit. A lot of big cuts coming in. We'll sneak in a few. Florida has a Medicaid STP that's outstanding. If you're listening to earnings calls for the big hospitals, they're all like, "Sorry, no news on Florida yet. We know that they're really working on it." And Florida's commercial rates are 3.5 times Medicare, and so this would be a very expensive STP. I'm eager to see the reaction from the Center for Responsible Federal Budget if Florida's STP gets approved. But we've got 10 minutes left, and I want to do a quick whip around of what's going on in the public and private markets. Starting on the private side, Doctronic raised $40 million.
Yeah, that was this morning, right? They just came out with that?
Hot off the presses.
Good for them. Obviously, we've talked a little bit about how they've faced some scrutiny recently from that the AI red teaming report from MindGuard, talking about how they hacked into Doctronic's model, resulting in some more lighthearted moments where they get the model start talking, and I think it was Creole back, some more concerning moments. But ultimately, and Doctronic talked a little bit about this in the Stat News article, it's a different program than what Doctronic's rolling out in Utah almost entirely. Doctronic, when we talked to their team, mentioned what was public facing was Doctronic 1.0. Utah is Doctronic 2.0. And to me, it makes a lot of sense that they are moving to a different version of the model that hopefully has less issues like that. They seem pretty convinced of that. I'm sure the investors behind this round are as well. It's going to be an interesting space to continue to watch. I have a feeling that this is not the last funding round we've heard about in 2026 for AI for clinical care in this country.
Next up. Oh yeah. I was gonna talk about Verily if you would like. So Verily announced a $300 million funding round. It's not small potatoes. And Alphabet is becoming a minority investor in the business with an asterisk, a little bit of an asterisk. Series X Capital led the round, and Series X Capital is a affiliated firm to Alphabet. Rounding out the round was the UC Health, the University, what used to be University of Colorado Health, and the University of Colorado Anschutz medical campus. And yeah, it's they're spinning it out, and Good for them. I think that this has been a long-term goal for Alphabet to get Verily off the books.
Yeah, I do not understand conceptually the UC Health, University of Colorado Anschutz involvement. Like I don't have a mental model yet for why the group of four investors is Series X, which as you mentioned is Alphabet affiliated, Alphabet, and then UC Health and U Colorado. I'm not sure. It's interesting.
So the University of Colorado and Anschutz, the Anschutz campus, Anschutz is my former employer, disclosure. They have a partnership with Verily for drug discovery. I think it's drug discovery. I will look into this and report back to you next time we talk. Kevin, you also might be wondering why a nonprofit hospital, which as you've heard, are just having a tough time of it right now and really struggling to make ends meet, and they're having to do cross-market mergers, is able to afford participating in a $300 million speculative investment in a private markets company. And to that, I would say UC Health has 10.7% EBITDA margins, and they did about $500 million in non-operating income in the first part of the year. So they're on track to do about $1 billion in non-operating income just from their investments. So good for them. That's how they can afford it. And that's
seems like
all
healthcare.
And that before, because that could be a longer rant. The debt markets tanked another deal. Kevin, what's going on?
So Qualtrics and Press Ganey announced a transaction October 2025. Qualtrics was going to pay $6.75 billion for Press Ganey. Broadly speaking, AI platform for consumer experience in healthcare. Makes sense strategically for the two organizations. Sounds like the banks nixed the deal on concerns over AI impact on businesses, broadly speaking, issues in the debt markets and how choppy those waters are. So it sounds like that deal is off at the moment, given the debt issues. That makes two kind of big healthcare transactions in the last couple of weeks now between that and Mr. Walden's Thoreau deal from earlier the year that got seemingly derailed by debt market issues. So I think it's something for us to keep an eye on over the course of the year, what's happening in those markets, and see if they settle down over time.
I would love for us to bring in a private credit expert, because for a really long time, they were just greasing the wheels on deals like this. And things have gotten choppier, and
totally. If one of our theories play, like go back to the public markets conversations we've had about valuations in private markets being better and public markets companies considering getting off the public markets and going private, it seems like a challenge for that structurally. If LBOs aren't able to finance debt in a reasonable way, you're not going to see those deals materialize, which is going to be a challenge.
And tough to find a bid if you are a privately held company of a certain size and you need debt to finance the deal. There's only so many people who can underwrite a deal the size of a Thoreau. Latent, an AI platform for specialty medicine approvals, raised $80 million. Man, this has been a hot space, and it really felt to me like we were maybe sort of at the top. And so it's a good thing that I'm not a venture capital investor, because I would have not called that correctly. Good for them. So they're working on prior auths for specialty meds. It's going to be a hot topic for the next few years. It's on our themes list for 2026. High cost drugs. Everyone wants to figure out how they can do it better.
For sure. It was interesting to see their uptake stats. They reported 45 health systems as customers. They got started, I think, 2-ish years ago, including half the top 20 systems in the country. So, I mean, I'm impressed by those numbers. That's not an easy feat to accomplish in a couple of years. Ochsner reported they were seeing 30% year-over-year growth in their specialty pharmacy business, working with Latent, which is just indicative of that market to me at the moment. Like as you said, we are going to be talking a lot about specialty pharma over the coming years. Another hot area that we've been talking about for the past few years, price transparency. Turquoise Health just announced $40 million. Led by Oak HCFT, big investor in the healthcare tech space, broadly speaking. They're almost at $100 million in total cap now. It's going to be interesting to watch how they they are transitioning from price transparency to a broader kind of contract management platform, which I'm curious to see how that goes. I mean, conceptually, it makes sense to me that you should be able to take that step from you've got all the pricing data to now you can help with the contracting front. They're apparently working with a bunch of health systems, payers, pharma companies, and insurance brokers already. And so if you're that infrastructure layer, strategically, that seems like a good spot to be.
Conduit Health, a DME platform, raised $17 million. This is interesting timing on this deal because DME vendors are paused at a national level right now. Enrollment in the Medicare program is paused because of some waste, fraud, and abuse concerns. But the DME space is one of those things where we spend a lot of money on it, and the experience is, depending on who you ask, bad to very bad, from the provider ordering it to the patient getting the DME. And so I think that this is an interesting space to watch. There's been a handful of these rounds recently. People seem undeterred by the federal scrutiny. And it's something I'll be watching.
Yep. Last funding round we noted from the week, Nadia Health or Nadia Care, maternal care model, $12 million. Altruist led the round, well-known value-based care investor. Nadia was formerly Kayaba Care, operating out of the East Coast, regional Medicaid plans, DC, Maryland, Tennessee. You love to see maternal care models focus on Medicaid populations. Excited to see that one.
The intrigue on this round was an unnamed national payer participated in the round.
I'd be interested who that is.
Yeah. All right. That brings us to the top of the hour. Kevin, this was super fun. I hope you have a great rest of your day. I'm headed over to AHIP. I will tell the CMS folks you say hello.
Give them our regards. We'll be curious to hear what happens at AHIP, how they talk about what's going on in MA and more broadly.
I'll be posting about it live in the Slack group.
Ooh. Yes. I'll see you there. See you, Martin. Happy Monday. Bye.